All right, that's great, Christian. Thanks a lot for the introduction. Christian asked if I would focus my talk on antimicrobials for this symposium, which I'm happy to do. And so I thought I would take a deep dive into the microbiome. And it's kind of nice because it touches on a lot of the concepts that have already been introduced today by Paul and Bobby. And ironically enough, I've been working with Acurx, with Bob, who just introduced the symposium with their new drug, bezapolstat. So I'll present some data there as well. And so in the next 15 minutes or so, I want to apply microbiome pharmacobiome principles to help understand why certain antibiotics have a lower risk of CDI recurrence and whether we could use that knowledge to then predict future antibiotics and whether they have a higher or low risk of recurrence themselves. So the antibiotic lecture with C. diff is not overly complicated. It's for initial CDI episode, it's fidaxomicin, vancomycin if you can't get hold of fidaxomicin. And for the first CDI recurrence, it's the same thing again, fidaxomicin over vancomycin, unless you can't get fidaxomicin. And then metronidazole is casually mentioned as if you can't get either of the other two, then consider metronidazole, but only for very mild disease. And that guideline from IDSJ mimics all the other major guidelines. The American College of Gastroenterology give it vanco or fidaxo. I just presented the IDSA guidelines, and the ECMID guidelines are a little more forceful, fidaxomicin preferred over vancomycin, and they really focus on the recurrence risk. If a patient is high risk for recurrence, then really choose fidaxomicin. And this is just one of the newer randomized controlled trials with fidaxomicin, but the earlier indication trials showed the same things. I highlighted in yellow the recurrence rates from this particular trial, the Extend trial. The blue is fidaxomicin and the red is vancomycin, and down is good because you don't have as much recurrence. And you can see you hardly see any blue and you see a lot of red. And so fidaxomicin has less recurrences than vancomycin. And that's why all the guidelines then prefer fidaxomicin over vancomycin. So for the Scientific Symposium this year, I'd like to take a deeper dive and ask the question, why does it have a lower CDI recurrence rates? And if you're casually walking down the hallway and chatting about C. diff, you will say it's a narrow spectrum antibiotic compared to vancomycin. And you're not wrong when you say that. That is the correct answer to the test question, but it is a little simplistic. So could we use our pharmacology and microbiome knowledge in a brand new word that you may not have heard of before, combine those two together, and what do you get? You get the pharmacobiome. And can we move this definition into the 21st century and really try to redefine what is a narrow spectrum antibiotic? Okay, so to understand pharmacobiome is to understand the microbiome. And this is then my own figure that I've used before. And this is your healthy microbiome on the left. A diversity of species, all producing something of health benefit to humans. And then when we use high-risk antibiotics that disrupt the microbiome, there's a number of different things that can happen. And one is you could just decrease the diversity of those healthy beneficial microbes. That's one. And then we've already heard about one, Clostridia taxa. That's the C. cindens that Paul mentioned, but there are many others. Actinobacteria is a major phylum of the human gut microbiome. You'll often have heard of Bifidobacterium. That's the superstar species in its class, common in yogurt, for example. So when we say diversity of microbiological species, we can be then decreasing these beneficial microbes that confer human health benefits. But at the same time, we can be increasing other things, other organisms that at present at very low abundance in our human gut microbiome do us no harm. But only when they increase in abundance do they then cause human disease. And this is a term known as pathobionts. But this is a poster child of a pathobiont is C. diff. About 3% of us are colonized with C. diff naturally. It's only when it produces toxins, it causes disease. But Enterococcus would be another big one. Gram-negatives like E. coli and Klebsiella. So you can get this increase of pathobionts, an increased proportion. Now I had some animation for this to make this a little simpler, but my animation is all here already. So I'll walk you through it. So this would be a normal microbiome study. So look at the very bottom left to begin with, and it says placebo 300 milligrams, patient 70,005. We'll just call that patient 5. And then you see the blue lines going across. So that the first two dots are the baseline, and then you see the baseline diversity of organism doesn't change if you're not on an antibiotic. Now go up to the top left-hand corner, my first box. That's one patient again. In this case, this patient is given vancomycin. Those two red dots up at the top, that's the baseline sample, so very diverse samples. And then as you see that sudden drop, that's illustrating the decreased diversity when you give an antibiotic, in this case, vancomycin. So that illustrates the decreased diversity. Now go over to the B side, the right side, and pick up on that vancomycin 125 milligram patient number 6, in this case, 70,006. And you can see it's a lot of green. That's the Clostridia, that's the good stuff. The purple is actinobacteria, that's also the good stuff. And then that red, that increased amount of red, the increased proportion of red, that's proteobacteria. So that's E. coli and Kleb. And so that's showing an overabundance of these pathobionts that we don't want. Now, if you go down to the second row and you see my second little bullet, you see ibezapolstat, and this is patient 9, you see changes, but you do see actually changes for the good in this case, and that's increases of actinobacteria. So now all of a sudden you're saying to yourself, well, wait, both of these antibiotics are changing, decreasing diversity, but they're changing them differently. One is causing increased abundance of pathobiont, and the other one is increasing abundance of actually something we like to have around. So that's taking your knowledge of pharmacobiome essentially to the next level. So then studies that we do essentially aggregate these data together, produce some means, and you see how does one class of antibiotics differ from something else. So congratulations, in 5 minutes or less, you're emerging pharmacobiome experts. So can we apply this knowledge to vanco and fidaxomicin? And then to do that, we need to bring in C. diff pathophysiology. And this is what Paul summarized in his slides. This is just in one slide only, which is nice. Because here's the normal microbiome in the top left-hand corner. This is that happy group of species that I showed you in my cartoon. And then we come along with high-risk antibiotics causing this susceptible microbiota, which, as we just learned, allows the ubiquitous C. diff spores to germinate and cause disease. Now, so these antibiotics set us up for the initial infection, but then the antibiotics that we give, vancomycin or fidaxomicin, then can also further disrupt that susceptible microbiota. And so the ideal antibiotic in antimicrobial stewardship will not disrupt the antibiotic to begin with. And in the treatment of C. diff, you want an antibiotic that is targeted towards C. diff and will not further disrupt the microbiome. So now I want to blow up that top slide, and I've just added in the left-hand corner the question of, so why is it with a normal microbiota that when we ingest C. diff spores, we essentially just poop them out the other side? They don't vegetate and cause disease. As opposed to when you have a susceptible microbiota, they germinate into vegetative cells and produce toxins. What's the difference here? And this is what Paul alluded to, and this is an emerging story of bile acids. So bile acids produced in the liver are secreted in small amounts in the colon as primary bile acids, where they are metabolized by certain components of our microbiome into secondary bile acids. And the poster child of that is C-syndins, which Paul mentioned, but it's a class of antimicrobials called Clostridia that can generally do this. And the reason why that's important for C. diff is primary bile acids actually promote the germination of C. diff spores. So if you have a high amount of primary bile acids, you'll promote C. diff spore germination. And secondary bile acids actually inhibit C. diff growth. So secondary bile acids are good, primary bile acids are bad, and that conversion is caused by a certain component of the microbiome. And now you're putting that into your pharmacobiome brain. You're saying, I like having Clostridia around, and any antibiotic that kills Clostridia then must be in that high risk for C. diff category. And you would be right. Okay, so here's then primary is bad, so we like to have that low. Secondary is high, and that's why in this case with a healthy microbiota, nobody germinates C. diff spores. It's because you have Clostridia in your microbiome, poster child C. scindens, and vice versa when you do get C. diff. So this doesn't come through very well. Actually, it comes through terribly because I blew it up terribly. But you can look at these things and you see very little red in these two top figures. This is what this is trying to illustrate, and lots of green. And that's people that got C. diff or they got an antibiotic, but they preserved their Clostridia class. And then if you go down below, you see lots of red, and these are patients that got an antibiotic that did not preserve their Clostridia, but had an overabundance of either gram-negatives, the proteobacteria, or enterococcus. And so by looking at these microbiome profiles, you could actually predict who's at risk for recurrent C. diff or not. Okay, so this is actually the drug that Acurx is developing, and to move this story along a little bit, I have to introduce it, ibezapolstat. Hard to say unless you've said it a few times, so we often abbreviate to IBZ. It's a unique molecular class. It's a Pol-3C inhibitor. And the Pol-3C is only available, only present in certain bacterial taxa, C. diff being one of them, staph, strep, anthrax, others, but not in all of them, not in all the components of the microbiome. So it's naturally a narrow spectrum antimicrobial, much like fidaxomicin, as we're using the same word. But can we use these concepts to ask the question, how narrow spectrum is it? And so this is a buddy of mine, Seth Walk, who's in Bozeman, Montana, and he maintains a germ-free mouse model, no organisms at all in these mice. And then you can take human stool and then humanize them with a human FMT, fecal microbiota transplantation. And so they're essentially a mouse with a human microbiome. And then you can test these concepts by giving them any antibiotic that you want, ibezapolstat, fidaxomicin, vanco, or metronidazole. This was just recently published a couple months ago, and it's a really good study to illustrate how different antibiotics affect the gut microbiome. And then here are the top level results. So this everything compares to your controls. Same as the patient populations that say, well, your diversity, if you're not giving an antibiotic, remains pretty constant. So you compare everything against your no drug controls. And this is the diversity plot that I showed you before, day 2 after therapy started. And you can see ibezapolstat and fidaxomicin tend to clump together. They don't lose much diversity. And then metronidazole and vancomycin tend to lose an awful lot of diversity. And that is present early and continue to be present throughout therapy. And so you'd say, well, ibezapolstat is just about as narrow spectrum an agent, if not a little bit more, than fidaxomicin. And then if you go over to the right, this is a beta diversity plot, and it's similar concepts, but how does the microbiome look? How does it compare to each other? And you do the same thing again. You rank it against the controls, and the closer you are to the control, that's less disruption to the microbiome. So then you see fidaxomicin and ibezapolstat once again clump close to the controls, and vancomycin and metronidazole then stay fairly far away from the controls. And so that illustrates that ibezapolstat is a fairly narrow spectrum agent, as would be predicted from the pharmacology. Now, I hope this works, and it's a good abundance plot on my next slide. So my colleague Taryn Eubank is going to illustrate the phase 2 study results from the ibezapolstat in her talk in about an hour. But to give you a hint, in the phase 2b study, there was 2 patients with recurrence. And I want to say, well, is this mouse and the theoretical stuff clinically important? And I want to highlight those 2 patients that had recurrence compared to all the patients in the study that did not. And it worked great, except for one little typo, which is fine. So in this is the same plot that I was showing you before. This is all the patients in this first proportional plot that had ibezapolstat. And you see lots and lots of green stuck around. And that's the preserved Clostridiales that would predict non-C. diff recurrence. And here in the middle plot, is patients given vancomycin who did not have recurrence. They also preserve Clostridiales. Now, these are the two patients in the right that had recurrence. You can see lots of increased abundance or maintenance of the proteobacteria. And then this different color green is actually a different pathobiont that I haven't introduced yet, something called negativity cuties. But this then is predictive that the Clostridiales is gone, and these are the two patients that had recurrence in the phase 2b study. This also illustrates in the bile acid story. So if your bile acid homeostasis is off, your secondary to primary bile acid ratio will be below 1. So the money shot here is in the C panel, the far right, and you can see lots of those red dots, those vancomycin-treated patients, have lost their bile acid homeostasis. And it persists for a long time. And take a guess where those two patients were at. They were at the bottom of those line charts. So I hope that's interesting. The science of the microbiome combined with antimicrobials is just tremendous. And it's pushing us into a way that we can clinically predict who's going to get recurrence or not. And it's going to enable us to rationalize therapies. It's going to introduce new therapeutics and diagnostics for us. It's really an exciting time. And C. diff has always led the way. It's always led the way as a poster child for a microbiome-mediated infectious disease. So I think if we can think of new drug development and even current drugs, kill the bug, spare the microbiome, and then this ushering in of the microbiome stewardship will add new patient-centered focus on to antimicrobial use, and hopefully more. Thanks again, Christian, for the opportunity to present today. I'm happy to take questions or comments or move on to the next great speaker, whatever you would like.
Oh, thank you so much, Kevin. If folks have a couple of quick questions, I'll be able to get to them. We're running a little bit behind. We did have a question from Melanie Baker. Said your slide with the bar graph of recurrence rates compared extended pulse fidaxomicin with a regular 10-day vancomycin treatment. Have you seen any studies comparing the extended vancomycin taper with fidaxomicin extended pulse? I'm still seeing many providers prefer the vancomycin taper over the fidaxomicin extended pulse. Wow, that's a lot of mycin.
That's mycin heavy. No, very little good data on vanco pulse taper. And that microbiome disruption that you see with regular dose vancomycin is most likely going to occur every bit as much with vancomycin pulse taper. It's an immediate reaction to almost each dose. So you're still going to see that increased enterococcus, increased proteobacteria, and not much benefit. There's a great paper this year by Nazia Safdar out of Wisconsin, who actually looked at secondary prophylaxis with oral vancomycin, a once daily dose, if I remember correctly, but don't quote me. Reduced incidence of C. diff while you were on vanco, but once they stopped vanco, it caught right up. So it prevents disease while you're giving it, but as soon as you stop, that disrupted microbiota makes you susceptible for C. diff. So in that randomized controlled trial, it showed that yes, it does delay, but doesn't prevent C. diff. So I do not recommend the vanco pulse taper if you can get fidaxomicin.
So let me we have a couple more and then we're gonna move on to our next speaker. Susan O'Brien asks, you've mentioned bile. I mean, that's usually whenever I'm talking. Might a medication like I've never been able to pronounce this one.
Cholestyramine.
Yeah. That affects bile help with C. diff risk or worsen risk?
It's a common and excellent question. So why don't we just give secondary bile acids? Like, that seems very reasonable given the pathophysiology. And the reason why we often say bile acid homeostasis in these types of talks is if I said, let's drop some secondary bile acids into that person, the colon cancer guys go ballistic because an overabundance of secondary bile acids is a risk factor for colon cancer. And so it's not so much an exact concentration of one versus the other, but how each individual's body metabolizes their own bile acids to convert them from primary to secondary bile acids. So it is what we should be doing. It's correct, but exactly how to do it is still to be determined. And weighing the risk of one thing for the benefit of another is what we have to then still to be determined. So stay tuned. This is a great story, which is continuing to get better almost daily.
Well, unfortunately, that's all the time we have with you, Kevin. Thank you so much. We greatly appreciate you always sharing your insights with us. And I'm going to turn it over to Paul to introduce our next speaker.
Thanks, Christian.